Oh, yeah.
Is that better?
Yeah, I just, with this one, I'm like,
Mostly podium, I think, because they'll both be there.
yeah, I was just
Can we
thinking
Zoom?
like, we can Zoom, but
Okay, then we'll miss the slides.
yeah, that's my, if I could
But I
revert.
think that's okay.
I think,
I didn't have time, I didn't tweak the lights.
what?
I didn't tweak the lights.
Tweak the,
The lights to see if it.
oh, I think we can do lights from here too.
Around a lot of these areas, and I'm sure that you will all appreciate that I've been vetted properly by Dr. Goldenberg. So I will focus on prostate cancer, BPH, lower urologic symptoms, and prostatitis. So what is the prostate gland? The prostate is an organ at the base of the urinary bladder. and it functions to produce seminal fluid. It is an ejaculatory organ, and it is a secondary sphincter. We normally talk about it as having three zones, a transitional zone, a central zone, and a peripheral zone. And there's a posterior and an anterior face to this gland that wraps around the urethra. It's actually part of the urethra when you think about it. And so BPH and symptoms like that tend to occur here in this transitional zone, whereas cancers tend to be found out here in this peripheral zone. So these are very distinct entities. When you look up close at the prostate, what you see is it has a very complex secretory structure. It is a series of glands. These tall cells are epithelial cells. These are the machines that produce all the fluids that get secreted. Around them are a rich neuromuscular stroma that allows it to be contractile. And we know first and foremost that the fact that we have a prostate is driven by testosterone. So androgens control this, and we know this from the work of Stamey and many others throughout the 20th century, how this all functions, that as a boy reaches puberty, his brain, his hypothalamus, starts to produce factors that drive the pituitary to produce factors that are the same factors that occur in women to drive their cycles. And in men, these hormones function to drive androgens production by the gonads. So testosterone is produced that functions on the prostate. Other organs in humans, like the adrenal gland, produce steroid-like molecules that can be converted into testosterone to help drive production or synthesis, growth of the prostate. And then testosterone feeds back on the brain to regulate how much testosterone is in a man. I promise this is as complicated as it gets. So testosterone circulates, bound to some globulins, and when it finds the cells that it's supposed to be in, it gets taken up by mechanisms that are really poorly resolved. And there's an enzyme called 5-alpha reductase, and I pointed out because Nick Bruchowski, who created prostate cancer research in British Columbia, was credited with identifying this particular activity where testosterone is converted into something called dihydrotestosterone, which is the high affinity ligand for the receptor. The receptor binds it, then moves to the center of the cell, the nucleus of the cell where the DNA is, binds to the DNA and drives expression of lots of genes that are associated with growth and survival, and we use one of these markers called prostate-specific antigen, or PSA, to monitor that activity. So the prostate doesn't stand alone. It is part and parcel of the urogenital system, and it comes from the urogenital sinus, and so it's part associated with the bladder, and it's a secondary sphincter for the bladder. It's associated with other sphincters, and it's innervated by the nerves. And so this is a complex organ, and we treat aspects of diseases of the prostate by functioning at all these areas. So the first one I want to talk about is benign prostatic hyperplasia. So I was taught when I came out here by Paul Rennie that prostate is gram for gram the most diseased organ of the body. So this is Paul Rennie's quote to me. And it is a stromoglandular hyperplasia, which means it can be overgrowth of either the stroma, this neuromuscular component, or the glandular part, the epithelial part. And so it grows and enlarges and can constrict the urethra. That's the simplest way to think about it. It happens to everybody. So a young man has a very small prostate. As we age, the prostate grows. It's inevitable. In some men, it grows faster than others, but it always does grow. And so minor symptoms can appear in the 40s and 50s. There can be a higher frequency of events in men in their 50s and 70s. Over half of men will have BPH of some sort at that point in their lives. And as men age, even more and more effects occur. And so this is a complex problem, and problem that needs to be treated. And so those of you who like graphs, I can show you here that the 50% point appears somewhere in the fifth or sixth decade of life. And then as we get older, almost everybody has it. So if this circle represents all men greater than 50 years old, these are the men who have histologic BPH. These are the men who have problems with it, prostatic enlargement, bothersome lower urinary tract symptoms, and BOO, which is obstruction of the urethra, and it appropriately called BOO. It's down here, bladder outlet obstruction. So there are medical treatments for BPH symptoms. 5-alpha reductase inhibitors, things that Nick had identified. We now have finasteride, dutasteride that can go after that enzyme and slow it down. And so that decreases the amount of testosterone that's driving the growth of the prostate. So that's meant to stop disease progression. alpha blockers that rapidly relieve symptoms, and these are in order to relax the muscles of the prostate and the surrounding areas. And so these are just the basic approaches that are used pharmacologically to treat BPH. When BPH is more problematic and obstruction is really severe, there are surgical approaches. Transurethral resections of the prostate are one such way to recreate a open urethra so that men can void properly. And so those are the basic approaches to BPH management. And I don't mean to make light of any of this. This is a real problem for lots of guys. But the key is that BPH is unrelated to cancer. BPH occurs in a region of the prostate that almost never becomes cancerous, although it can be invaded by cancer. And cancers appear on the periphery, and they have to be pretty bad in order to create the constrictions that show up in BPH. Although there are certainly crossovers, and I know too many stories that are crossovers. The other major, and maybe the most major issue of the prostate is called prostatitis. And it's an enigmatic disease. It is the most common urologic problem diagnosed in men under 50, and third most common in men over 50 because BPH and cancer rule those men. And it's broken into 4 different classes, and it's fine that this last one get cut off because the last one is actually asymptomatic inflammatory prostatitis. So there's inflammation of the prostate, but it's asymptomatic. So it gets diagnosed for other reasons. The man doesn't even really know he has it. The first is acute bacterial prostatitis, where there's a urinary tract infection. There can be chronic bacterial prostatitis because it's hard to clear infectious agents from the prostate once they're there. And then the majority of men present with an etiology that looks like they might be infected, either from an inflammatory or a non-inflammatory pain syndrome perspective, but for which there's no infectious agent detectable. And so how do we manage this? We can target the infectious agents, we can reduce inflammation, we can try to improve urodynamics. And there are lots of ways to do that. So same sort of script. Antimicrobials, when you know that there is an infectious agent, you can go after them. Don't try to use antibiotics when there's no bug, but certainly there are lots of different ways to go. You can use anti-inflammatories, just over-the-counter anti-inflammatories. Sometimes they're of some benefit. You can use, again, alpha-adrenergic receptor antagonists in order to relax the muscles and allow symptom relief. We can use 5-alpha reductase inhibitors to inactivate the androgen receptor signaling cascade, try to reduce any extra growth that's going on if that's what is causing part of the inflammatory processes. We can use analgesics of all sorts, and I believe this is actually a topic here sometime during the 5 weeks, right? Cannabinoids in healthcare? Yeah, for sure. Yeah. Preferable to opiates, that's for sure. And then target contraction relief, just physical therapy can also sometimes help. But my real focus and my real function is to discuss prostate cancer and what's going on in prostate cancer and how we're making progress in this disease. So prostate cancer is the most frequently diagnosed cancer in men. It parallels the accessory sex organ cancer in women, breast cancer. Over time, prostate cancer has dropped below colorectal cancer as the 3rd leading cause of male mortality, whereas breast cancer still is the 2nd leading cause of mortality in women. Both fall far behind lung cancer for mortality, although lung cancers are not quite the same height as they are at incidence because of the lethality of that disease. And so I show this because prostate cancer's incidence rates are actually quite intriguing. So when I got into the field back in this era, we had a diagnosis rate of about this. And over time, it spiked up. And then declined, and it spiked up and it declined. And I thought about this curve as I was driving in from the ferry because I could see the mountains on the other side of the strait. That's what it looks like. And so it's a really interesting schema. The others are all really straightforward. Lung cancer has been declining with our understanding of what causes lung cancer and trying to remove those sorts of effects from the environment. Things like bladder cancer and colorectal cancers have remained relatively flat in their incidences. Again, lung cancer mortality has declined precipitously with improved understanding, as have colorectal and prostate cancer over some period of time. But this prostate cancer line is a very peculiar thing. And so it's important to understand why we think that actually has occurred. So there was an introduction of a blood test called prostate-specific antigen testing that was introduced in the late 80s. And that allowed for detection of what we consider to be a lot of indolent or otherwise undiagnosed cancer. And so we had this spike in incidence. And are a lot of men who got treated during this era who might not have needed to be treated, but there they are. There was a concern that the screening was over identifying prostate cancers, and so there was a rebound. And then they crept back up again, there's a rebound. And now, where's my next slide? Oh, we're out here, where when it first started going down again, I thought, okay, we're just going to get another bounce. But it's now been a decade of declining incidence, solid declining incidence. And we don't really understand why there's a declining incidence. There is some understanding of trying to diagnose cancers that are clinically relevant versus not clinically relevant. That certainly plays part of it, but I'm not sure that that's the whole story here. So time will tell, but in epidemiology will tell, but there is a steady decline. So that's good news. There's also been a steady decline in mortality, but still what we recognize is that 1 in 8 men will be diagnosed with prostate cancer in their lifetime. And while there's been a 40% decline in mortality since the introduction of PSA testing, still 1 in 27 will die of prostate cancer. An improvement from 1 in 20, which is what I was saying not too long ago. So how does prostate cancer occur? Well, it occurs in those glands that I showed you at the beginning. When one of these cells, one of these machines that has to continue to produce factors for the prostate fluid to be produced, when they have to be replaced. Just like every other epithelium, skin or whatever, they have to be replaced. And so there's a need for those cells to be able to divide over and over again throughout the life of the man. And there's a chance that they make a mistake somewhere along the way. And so one of them makes some sort of mistake, be it genetic, be it due to some environmental insult or some other metabolic syndrome. Lots of different reasons can cause the cell to start to grow abnormally. And so these cells will start to grow. And we generate something that we call prostatic interstitial neoplasia, or PIN. Prostate cancer, much like BPH, increases with age. And we know that a man 80 years old has an 80% chance of having these sorts of interstitial neoplasias in their prostate. And most men die with it, not of it. And so these are sort of the problematic ones we can detect. We need to be really careful about whether we start to treat or not. What we do want to know is when the transition goes from these sorts of PIN lesions into localized disease, where the cancer has acquired the ability to leave the gland, to escape into the muscular space, because this is the tissue, this is the cancer that we want to be able to treat, identify and treat, because if we leave it unchecked, then the cancer has a high probability of metastasizing, of leaving the prostate, getting into circulation, lymph system, and homing into different organs of the body. In prostate cancer, the organ that it predominantly homes to is the bone. And so I'll get back to that at the end, but the bone is really the most problematic area for prostate cancer metastasis, similar to what happens in breast cancer, although there are also major differences. So prostate cancer has a lot of risk factors, and not all risk factors are the same. Risk factors are just that. So there are unmodifiable risk factors, age, race, and family history, and those things we can't control. But there are a variety of modifiable risk factors that are, well, not necessarily able to trump these things, can certainly mitigate some of the other risk factors. So geography, diet, exercise have all been things that have been attributed with having an impact on what prostate cancer is. So this is out of the SEER data set. This is a graph that I used to try to explain the discrepancies between racial backgrounds and over age. So in the United States particularly, so African Americans or black people have a much higher incidence of prostate cancer, and they actually have a much higher mortality of prostate cancer as well, as compared to their Caucasian brethren or Hispanic brethren. There seems to be a drop in natives of North America and in Asians. And so, again, how this actually plays out remains to be resolved. I'll show some more data on that. But this big gap here has been something that's been a big focus for decades and remains not completely resolved. But of all cancers, prostate cancer increases most dramatically with age. And so you can see that there are easily men detected, diagnosed early in their 40s and those sorts of things, but that the peak is out here around 68, 69 years old. So risk, what do we think about family history? So we think that about 60% is just sporadic cancer, has no family history at all, whereas about 40% have some genetic component. And while we can understand specifically some of those genetic components, A lot of them remain to be determined. We have lots of guys who have this family history, but we can't nail down exactly what the genetic mistake is. And these are very close to what happens in breast cancer, where there's a much better resolution of familial versus hereditary diseases, and in colorectal cancer, where lots of specific mistakes create subclasses of disease. And I'll try to get to some of the genetic mistakes in prostate cancer in a bit. So family history. 1 in 8 is what I said, is what our probability is just generally. But if we have a brother with prostate cancer, our risk goes up twofold. If we have a father and a brother who have prostate cancer, our risk goes up fivefold. And if you have more probands in direct descendants or direct relatives, then your risk goes up even higher. And there's a real push to try to understand what happens to these guys, identify what the mistakes are, and develop therapeutics to go after some of those things. So geography, location, these sorts of things are a bit problematic. Whether it's diagnosis, willingness to diagnose, seems to be part of it, but there also does seem to be components that are related to exposure to environmental carcinogens and those sorts of things. And so this graph is meant to show that. So here's a list of people from Asia. In Asia, their incidence and mortality rates. And you can see they're all relatively low compared to the North American cohort, where the incidence rates jump dramatically. And while the mortality rates also increase, they don't increase anywhere near as dramatically as they do for incidence. And so certainly diagnosis is occurring at a much higher rate here. Is it because they're just going undiagnosed here, or is it because of exposure to factors in the new world that are causing an incidence in cancer? Are issues we'd like to know. There are issues related to dietary factors. What this graph is meant to show is factors that are positive or negative for it. So it's everything your mother told you. Eat your vegetables. That's good for you. Stay away from the French fries. They're not good for you. We can do those sorts of things. So prostate cancer identification has always been problematic. You guys can read as well as I can. This is a long list of things that are considered prostate cancer symptoms. And in extreme cases, these would certainly be cause for concern, but most men my age or older can chalk this up to a bad beer. And so, symptoms are typically not very helpful. Most men I know that have been diagnosed with prostate cancer were not diagnosed because of symptoms. Some have, but not most. So early detection saves lives. We know that from breast self-examinations and all the things that have happened in that area. Prostate self-examination is a different issue altogether. So how do we do this? So diagnosis of prostate cancer is really a three-part problem. Certainly, digital rectal exams are the fastest, easiest way to screen a man, and everybody in their 50s should be doing that. Back in the days of conscription service, guys who got conscripted got one of these when they walked in when they were 18. And that was silly, but still, we do that. So DREs are great. If there's a suspicious DRE and or elevated PSA in a blood test, then those things can trigger a desire by the clinical community to want to do a biopsy. And the biopsy I've circled here because that's really the only way to date that we have to formally diagnose cancer. We let a pathologist look at the tissue and say, yeah, that's cancer. That's what it is. Imaging is coming a long way, and we'll probably supplant that at some point, but for now, we still need that biopsy to be able to say there's cancer, and then to get some other gauges about how much there is and where to go with it. So the DRE is actually very simple. And the reason is because a lot of the cancer forms on this posterior side of the gland, and it forms hard spots and bumps, and the finger can find it. The finger is an amazing tool. PSA is a little different. So PSA is one of the factors that prostate epithelial cells are producing and normally secreting into the luminal space in order to be part of the ejaculate. And it functions to liquefy sperm and help release their motility. It's attributed with other activities as well. So the vast majority of it ends up in the seminal fluid. Some of it always ends up in the blood, but a little. And so that number increases with time, but a little. In prostate cancer, the cells lose their organization. They lose their structural integrity, And so they lose sense of up and down. And so they'll secrete in all directions. And there's a break in the basement membrane, so it gets released into the cellular fluid and it gets taken up by the lymph. And so we can see it in the blood. So that's why PSA tests showing an increase in PSA really fast over time can be quite indicative of a cancer or some other event. However, there are lots of things that can elevate PSA. Lots. So many. So it, in and of itself, is not a cancer test. It's a test of PSA. Just like the DRE is not a cancer test, it's a test of the overall health and wellness of the gland. So that's why there has to be a biopsy or some other objective way to examine the tissue itself. So while we use PSA for early detection, staging once diagnosed, and post-treatment assessment and management, it can also be an indicator of things like BPH and prostatitis. So what is this biopsy I'm talking about? Well, the biopsy is an invasive technique where a truss ultrasound is performed. So there's an ultrasound that helps guide where the needle goes. Typically a dozen or a few more samples get taken, hopefully from areas where they think the prostate cancer is, they being the pathologist and the clinicians. And so the needle goes in and takes a little core. And then you can examine those microscopically and say, well, here's a little cancer here. And you can say what percentage of the cores have cancer and what percentage of each core is cancerous. And that becomes a really helpful guide for the urologist to help inform the patients and determine what strategies they should take in order to manage this. So we have a scoring system that was generated by Dr. Gleason back in 1966. And we use it still to this day. And he drew this on the back of a napkin. And I had old profs back in the day who used to hold court in barbecue houses, and they drew on the back of napkins too. They were really fun to have around. Everyone would take the napkin. I did it once for a postdoc here, and I would do it all the time, and he kept taking them. And one day, he was giving a seminar, and he put one up. It was quite funny. And so I've quit handing those out. But anyway, so grade 1, basically not really cancer, small uniform glands, they look normal. Grade 2, the acini, these glands start to get separated, their structures aren't quite right. Grade 3, there are more and more variations in size, stromal infiltration, there might be blood cell infiltration as well. Stage 4 starts to look pretty grossly cancerous. And in grade 5, sheets of blue cells, one pathologist told me. Sheets of blue cells, because they're just really small. The cells are dividing really fast, and the dye we use for the DNA is blue. The dye we use for the cytoplasm is red, and they just look blue, because there's almost no cytoplasm around. What happened, though, all right, so then we score it. And so we have grade 1 to grade 5. And Gleason said what you do is you take the most frequent grade, and you add it to the second most frequent grade. So if you have 2 3s, you call it a 6. If you have a frequency of 3 and a bit of 4, you call it a 7. But at the same time, you have a lot of 4 and only a little 3, you call that a 7 too. And so that becomes sort of problematic. The other problem was that over time, the community recognized that Gleason 1 and Gleason 2 were not clinically relevant disease. And so they quit being scored full stop. And so cancer was scored 3, 4, 5. And so the lowest score you could get was a 6. Congratulations, Dr. Cox, you have prostate cancer, but it's really low, you have a 6. And I can count, and there's a lot of numbers lower than 6. And so it really causes concern in the community, and everybody would cause concern in me. And so there's a contemporary effort to change this scoring system to using a grade group. And this has been headed up by Epstein and colleagues in the States and is getting some traction. And so the idea is that these grades haven't changed. Everybody knows how to do these gradings, so the grades haven't changed. So anything grade 1 to 3, so a 6 or less, is called grade group 1. These are low-risk prostate cancers that can be effectively managed by active surveillance and follow-ups as things get worse, if they get worse. Then we got to this 4-3 and 3-4 problem. And so there was a separation. So grade 2 is 3-4. Group 3 is 4-3. So now there's a difference between those two. And that's really important because what I'll show you next is that there's a really clinical difference between those two groups. Group 4 and Group 5 are bad. So this is the one we want to focus on. And what you can see is that if you look at probability of recurrence-free progression. So the rates at which men who have surgery or or radiation therapy develop subsequent disease, elevated PSA and detectable disease, that number is actually quite low for group 1 and group 2, but jumps dramatically for group 3. So there really is a need to separate these two groups, this 4-3 from the 3-4. So we're hoping it takes traction. I like it. I think it's a good idea. Then we also want to know staging, and we call it the tumor node metastasis staging. And it's used in lots of different cancers. So how much tumor you have, small amount, large, more. Okay? And when these grade 3 and grade 4, you're talking about disease that's actually gotten outside of the prostate. And that's a bit of a problem. So you want to know what these grade 3s and 4s are versus these 1s and 2s. We also want to know lymph node status. So if there's evidence of disseminated disease, the first thing that will happen is there'll be an effort to try to understand whether there's any in surrounding lymph nodes, and if it wasn't looked for because it was grade 1 or stage 1 or 2, then typically it'll just not get scored at all. If it is potential stage 3 or 4, clinicians will look for those lymph nodes, and it might be that they scored none or they scored some positive. And then metastasis. And so distant metastasis is not assessed, not seen in a bone scan, typically seen in a bone scan, or in non-regional lymph nodes or other sites. So how do we treat? So localized disease, curative intent is primarily radiotherapy and surgery. And there are lots of different ways to pull these tricks off, and that's how it happens. For guys with low-risk disease, there is active surveillance. So monitor the course of disease and make determinations as you go. So why? Why not just treat everybody? These things have high cure rates for low and intermediate risk disease, which means that we may be treating people we don't need to treat, and then treating people for whom it comes back anyway. And the problem really is that there are real impacts on quality of life. So there are impotence rates, there are urinary incontinence rates, all kinds of issues that arise from these sorts of therapies, which makes perfect sense because you're ablating this organ that sits in this system. The nerves that run into the penis that are associated with sexual function are compromised. The ability to control urination is compromised. Going after the prostate is not as simple as one would like. The problem with active surveillance is we haven't yet certified how to do this on a consistent way around the world, much less within the province. So each urologist has his own way of wanting to monitor active surveillance, and it also is balanced by the patient's risk aversion. So there are issues that are surrounding active surveillance that really need to be fleshed out over time. Our colleague Dr. Klotz in Toronto has been a world leader in promoting active surveillance, and if you ever get a chance to hear him talk, you should listen to him because he's very persuasive in his arguments. When disease is disseminated, we have to figure out what to do. So if disease has disseminated prior to intervention or after intervention comes back, the primary therapy is called hormone therapy. And this is going after that androgen function. And so that's what I told you at the beginning. The prostate is driven by testosterone and the disease is driven by testosterone. So going after the hormone axis is first line and has been since the 60s. And it was done because of this guy here, a Canadian from the east of Canada who did his Nobel Prize work at the University of Chicago, who established that castration, or androgen withdrawal of some sort, almost always results in a regression of prostate cancer. Almost always, like 99% of the time. And became this established androgen pathway as the first credentialized therapeutic target in prostate cancer. I should put that in quotes too, because that belongs to Martin Gleave. And so now we have lots of ways to do this. We can start at the brain, and we can go after the ability of the hypothalamus to communicate with the pituitary. We can castrate. That's actually still happens sometimes. We can go after steroid synthesis that's outside of the testicles. And we can produce factors that are anti-androgens that actually competitively compete for the ability of testosterone to bind to the androgen receptor. And all of these axes are used today. The problem is, and Huggins knew it then, back in the 60s, was that for the vast majority of men, while there is a protracted period of time of remission, progression is almost inevitable. And I actually dedicate today's talk to a friend of mine, Ted Butterfield, who we lost last week, to this disease. And he sat in this window of time for a decade with no evidence of disease at all. And then it came ripping back. And Ted wouldn't mind me telling you, because he was very public about it within the support group communities. And these are the kind of stories that happen. A long time and then a rebound. What do we do about these guys? That's our lab. Yes, sir.
Yeah, you're right. My father, 6 years that time.
Yeah. So dormancy is a huge problem. And breast cancer is way ahead of prostate cancer and is trying to understand dormancy. Love to talk about it. Not going to talk about it today, unless you ask a question later, okay? Okay. The other thing we know is that out here, the androgen receptor is almost always still at play, at least in the initial stages. The androgen receptor still gets activated, it's still functioning. That's what these little brown dots are, is active androgen receptor in the nucleus of these cells. So what do we do about disseminated disease? I should kind of move these around, but chemotherapy and targeted therapies are where we are. So what do we do? So this is the modern view of the natural history of prostate cancer. We can have local therapy, failure for those guys who fail, the 20% that fail, hormone therapy, maybe some chemotherapy. Docetaxel is the only approved therapy at that level. Then we can have salvage radiation therapy that often sometimes happens in here. Second-line androgen receptor pathway inhibitors. There's an emerging idea about immunotherapies and DNA repair therapies that I want to talk about a little bit. More chemotherapy, post-chemotherapy with androgen receptor pathway inhibitors, some salvage chemotherapy. Platinum, especially with disease that actually loses the androgen receptor and starts functioning more like a small cell cancer, and radiotherapies that are emerging. So I do really want to focus on a few things, enzalutamide and abiraterone and their related partners, and one down here that I'll talk about when it'll be at the top, olaparib. Okay, so I told you that prostate cancer was basically a sporadic disease. And for a long time that was true. And I remember the first time I studied this molecule here. And when I first started talking about it and said there were subtypes of prostate cancer, I had a pathologist in an audience say, you can't say that. There's no such thing as subtypes of prostate cancer. And so here we are a decade later, and I get to say it. So that's nice. So there are subtypes of prostate cancer. This has been validated by a number of high patient number genetic analyses that break it into different subsets. So fully half of prostate cancers have some associated X family member dysfunction. Some have other mutations that can be identified. For those of you who are interested, we can talk about. And what they do is they seem to play into DNA hypermethylation or control of what the genome actually is for these cells, what genes they can and can't express. Androgen receptor pathway activation is always prominent. DNA repair defects have been identified and are very useful. And then various pro-survival signaling pathways that we think are really important in trying to treat these things that for my money, fall into a metabolism angle and the kind of things that we can do from a metabolism basis. Something didn't happen. Oh yeah, I'm going to focus on that one. There you go. So olaparib, I told you I'd put it at the top. There it is. I'm going to make it. So this is a cartoon from the first trial that actually created an FDA breakthrough therapy designation for using olaparib in prostate cancer. So olaparib targets an enzyme called PARP, this guy here. And it was first shown to be very useful in women with breast cancer and ovarian cancers that carried mutations of specific genes, BRCA1 and BRCA2, which I'm sure most of you have heard about, and ATM, another related factor that drives that DNA repair pathway. And the idea is called synthetic lethality. So the cell has really three ways to repair DNA. Nobel Prize was awarded for that a couple years ago. And of those three pathways, BRCA1 and BRCA2 and ATM control one of them. And so if that's lost, the cell relies on the other two pathways. And there turns out to be a drug called olaparib that goes after one of those other two pathways, the key component of it called PARP. And so if you can take out PARP when this pathway is broken, then the cells have a really hard time of repairing themselves, and their DNA will continue to degrade till they die. So this has been the basis of this sort of therapy. And basically, the initial scan indicated that guys who were positive responded really well. Guys who were negative didn't respond, with the occasional ATMs that also didn't respond. And then we knew from the breast and ovarian cancer literature that if there was a mutation, that the treatment was almost 100%. And this is a very small number, but we now have thousands and thousands of women that have been treated with this drug. And it's not 100%, but it's pretty darn high. And then what we want to do is find out whether men have developed or women have developed this in their cancer. And for those who have developed it in their cancer, response rates are really, really relatively high, whereas the no mutation guys tend not to respond. So this is a first glint at how you can do functionalized therapies that aren't necessarily personalized, but are certainly subcategorized and goes after a specific subset of disease. All these cartoons, I'm sorry. Okay. The other really exciting area in prostate cancer therapy that is on the horizon, almost here, is something we call Theranostics. And I have an interest in this with Dr. Goldenberg, and there are a lot of groups around the world that have been doing this for a few years now. And the idea is that if you could find something that the prostate cancer cell makes, that you can have a small molecule or an antibody to that is highly selective for that particular factor, and you can conjugate to that molecule some strong radionuclide, then you can get that to bind, taken up by the cell, where it'll blast that cell. Radiotherapy on a cell-cell basis. And it's a great idea. And it would be wonderful if we had something that was on the surface of prostate cancers, everybody's prostate cancers, that we could work with. But that just isn't the case. And I show this data because it comes from this guy, Michael Hoffman in Australia, who was the first to really recognize that you couldn't just treat everybody the same. That first thing he wanted to know was, how much of this marker, PSMA, does the patient's prostate cancer make? Is it all the lesions? Is it a few of the lesions? If it's the majority of the lesions, he'll treat. If it's not, he won't, because he recognizes that if he treats the guys who have mixed cancer, then they won't all, then the cells that don't get targeted don't get treated. There isn't much of a bystander effect, and we just don't kill those cancers and they continue to grow. In fact, they'll take over. A niche is opened up and they'll take over. But for the guys that he is reporting, and he's showing these 6 guys here, you can see they had detectable disease, they got treated, and it was almost undetectable. Here's a really dramatic example of a guy whose skeleton is just littered and how well he responded. Similar here, here, here. Not so well here, not so well. So this represents these guys here. And he says that overall, from the number of patients he's been treating, he's seeing about a 13, 14-month improvement in overall survival of these men. And so that doesn't sound like much, but you have to understand these are men that are really at death's door. This is a dramatically close case. And so you're dealing with men who have tried everything, and this is all that's left. And so once these sorts of studies get done, and there is evidence of an improvement even at this case, then there's the opportunity to phase forward that therapy into earlier and earlier stages of disease to try to treat men at earlier times to affect cures, if not really prolong survival. The other area that's of great interest in prostate cancer, certainly behind areas like melanoma and pancreatic and other cancers, renal cancers, is prostate cancer immunotherapy. And there are a few different ways. There is one approved therapy called Subtype C, in which a patient's white blood cells are taken out, immunized, and then put back into the patient in order to drive an antibody against specific genes that can help clear that patient's cancer. There are other sorts of immunizations that are very similar. And while they're somewhat effective, they really haven't gained a lot of traction. The survival time improvements are actually quite modest, and they haven't phased forward very well. So there are other ways that people are trying to go about it. And those include immune checkpoint cascades, which have been very effective. You'll hear about things like CAR T and other sorts of approaches that are similar to these sorts of approaches to antibodies that are being used. And so there is a real effort to try to make these things a reality in prostate cancer. Prostate cancer tends to be a relatively cold cancer, immunologically cold cancer. It doesn't present a lot of neoantigens, so the immune system doesn't really respond to it. And this is probably because it has a huge component that is more metabolic than anything else. The cells are functioning in a dysregulated metabolism as much as they are genetic mistakes. Of course, they have to have genetic mistakes because all cancer is inevitably a genetic disease, but metabolism seems to be a really important component of it. So I'm at 1:45. I'm going to close here really quick. What I want you to go away with is that prostate cancer, 5-year survival actually looks pretty good. So it has dramatically improved over this period of time from here to here and continues to get better. This is all comers, yet we still have a long way to go. We're trying to understand the guys with that highly relevant clinical disease and how to treat those guys. And prostate health is more than just cancer. There are lots of other risk factors that are associated with this. The list is here. The one thing I didn't really talk about is exercise, and I decided I'd throw one more slide in as a transition. But first I want to comment on a couple of places you can go in order to learn more. So there is something called the Men's Health Foundation. Larry Goldenberg was a major player in getting this started. They have a lot of good information. The internet is full of bad information. This is good information. And one of his major issues is something that they don't change much. How do you get healthy overall? Check. What is your risk assessment scores? And then just other ways to get in to help these guys out. Prostate Cancer Canada, who support me, support lots of us across the country. I've been working with them for a long time. They provide a lot of good information, webinars that experts give, sometimes I give, other information services, events across the country, well worth considering if you're looking for information regarding prostate cancer. And then here, our local community, we have something called the Prostate Cancer Foundation of British Columbia, of which I'm a board member. And this foundation helps manage over 24 support groups across the province and works closely with Prostate Cancer Foundation out here in Victoria and have really helped make sure that men get the word. And we have recently put up an interactive website called If I Were Tom that helps men walk through diagnosis and treatment options. There's a cut to the chase set of videos. There are other interactive videos and more on the way. And we're really excited about the ability to use this sort of internet tool to help guide men's decision making. So as far as exercise is concerned, it's your call. And I'll take questions. Any more? Yes, ma'am. Yeah, use the button. Yeah, bash the button.
Yeah.
There you go.
Of all the therapies that you talked about, the immunotherapy and then I wrote it down, the Theranostics.
Yes.
Are those therapies in clinical trials now?
Yes, absolutely.
Oh, they are. So patients coming into BC Cancer, are they offered opportunities to participate
Depending on their eligibility, for sure.
Okay.
Right, so from the Theranostics perspective,
Right.
that's actually in BC a little more advanced.
Right.
And so there is a PCC-funded Trans-Canadian initiative to get Theranostics assessed in Canada. And that's been going on now for less than a year. And it's being run out of the BC Cancer Agency sitting in at UBC on the main
Okay.
campus. But I think it's also going to reach out to other places as well. But that's where the
Right.
infrastructure is. We need to have access to Triumph and get the radionuclides produced and that sort of
Oh.
thing, right? So there are some issues there, but that's being driven from there.
Right.
The immunotherapies have not taken hold here in Canada. It's a matter of cold cancers, the lack of evidence of much success, and the inability to identify who to treat. And so that's much stronger initiative in the States right now.
I
And
see.
a lot of work coming out of Oregon, for example, and a few other places that are really interested in developing these immunotherapies. That's not to say it's not going on. There are certainly trials that are going on in New York and across the United States, and when appropriate, guys will get routed into that, but it's when appropriate only.
Right.
And it's been a really interesting area. In fact, we have a company called Zymeworks in Vancouver
Yeah.
that is dedicated to this sort of approach in all sorts of events, malignancies included. So they have a immuno-oncology program that's very dedicated to this. They've had a hard time getting traction in prostate cancer. They're working in other malignancies. They can't really see how to get to prostate cancer yet. So that's the biggest hole right now, is how do you convince the prostate cancer cell to produce things that the immune system sees. If the immune system can't see it, those approaches won't work. And so
Wow.
I'm trying to understand that.
Okay, thank you.
Yes. Okay, you click out, he clicks in.
Yeah.
You hit the button. Yeah, so the people on the internet can hear you.
There, thank you. PSA has an element of a false positive.
Absolutely. Well, it's not false positive. It's a positive PSA. It's just not a cancer diagnosis.
Right.
Okay?
So is there a role for PSA3?
So PCA3 is not a protein, it's an RNA, and produced by the prostate. And so it seems to be pretty definitive for cancer. It doesn't say what kind of cancer, But if there's a high PSA and an unremarkable DRE, a PCA3 test is actually a pretty good test if the patient really wants to avoid a biopsy. But if the PCA3 test comes back positive, there's a biopsy anyway. If the PCA3 came back negative, you're probably on active surveillance with watching the PSA over time. So yes, absolutely. It's not covered, but it's out there. Yes, sir. You have to click out, yeah.
Thank you. This was really, really good. You talked about DRE
Yes.
and followed by PSA, or
Yes.
possibly both. You didn't mention anything about colonoscopy. Can you just say a word about
Sure.
how
So
important that is and where it
colonoscopies,
fits
yeah,
in?
so colonoscopies are meant to address the other orifice, right? So the GI tract, colonoscopies, is looking for colon cancer. And this was meant to be from a urologic perspective, but certainly colorectal cancer is a huge problem, and colonoscopies are the best way we know to go about trying to identify those, other than the simple FIT tests and those sorts of things looking for blood in the feces. But a colonoscopy is an effort to try to identify polyps and lesions that are in the colon itself. And so that's a colorectal approach. Follow up? No? Okay. Yes, sir.
Any work to find treatments that convince the cancer cells to commit suicide, apoptosis?
Yes. So hormone therapy is thought to convince the cells to commit suicide, to undergo apoptosis. Necrosis is fine too. We don't really care how they die. In fact, necrosis might be better. The olaparib is meant to do that by causing so much genetic damage that the cell eventually just necroses. There are other sorts of therapies that go after this. I mentioned this PI3 kinase pathway. And so there are approaches that are trying to be developed, yet to be certified in prostate cancer, that would address these pro-survival pathways that would allow the cell to reveal how sick it actually is in order to induce either an intrinsic or an extrinsic death. But there is no trigger for apoptosis aside from that, other than metabolism sorts of approaches.
Not that the cell is sick, it's different.
Yes, so my lab is very interested in cholesterol, for example. And we've recently reported that we were interested in cholesterol because cholesterol is a precursor for testosterone. And we've been working from the perspective that in order for these cancer cells to progress when ostensibly all body testosterone has been removed, the cells must be producing their own testosterone, or the tumor must be producing its own testosterone. And there's plenty of literature for that. And cholesterol is the key precursor. And so we've been looking at the role of statins and the role of other approaches to try to remove extra cholesterol from the body to decrease that testosterone production. And we can easily show that you can do that. But what we found was that it wasn't just the testosterone production. If we could throttle the amount of cholesterol the cells can take up and have as metabolically available testosterone for rapid cell division and production of mitochondria and endoplasmic reticulum and those sorts of things, that the cells actually enter an autophagic state. They are under a lot of stress. The mitochondria will start to shut down, they start to get enveloped, and so we think there are real opportunities to take advantage of some of that. And that's what my Prostate Cancer Canada grant is all about, is trying to identify those synthetic lethalities so that we can convince those cells to die when they've been deprived of cholesterol or other key nutrients. Yes, sir.
Is there a role for MRI in definitive diagnosis?
Absolutely.
Are we using it here?
More and more every day. More and more every day. We in British Columbia lack facility. Infrastructure is our biggest problem. And if we have any way of convincing the powers that be to put more imaging capacity per capita into this province, we'll be way better off. But MRIs are being used more and more, with an understanding that there's improved contrast agents and those sorts of things. And so I know a lot of guys that are in that same boat relative to PCA3 tests, have an enlarged prostate, a rising PSA, waiting, whatever it is, 6 months or whatever, to get an MRI in order to determine whether or not there's anything that's actionable as a lesion in the prostate to help guide that decision-making process. And yeah, it's gaining traction. It's getting better every day. Follow up.
One little bit to that. Does that replace a biopsy?
Never.
It doesn't?
It can't.
Okay.
Yes, sir. Yes, ma'am.
I have a question about translation. Once we have the diagnosis and the patient is, of course, interested in treatment, I'm interested in the Gleason scale and translating that for people either into a different set of grades or even more than a different set of grades, words that somebody who hasn't read the literature can understand.
This is a huge issue. And it really is a huge issue in prostate cancer because we know from historical data that 80% of men diagnosed with prostate cancer will not die of it. 80%. That means we don't need to treat 8 out of 10 guys that get diagnosed. Yet we do not know definitively who those 8 are, or who the 10 are, or 20 are. Sorry. We just don't know. And so, to date, the strongest stat for that is a combination of the Gleason grade and the stage. If you have high volume disease and aggressive looking cells, your risk of dying of disease goes way up. If you have low volume disease and low Gleason grade, normal looking cells, even though it's cancerous for sure, your risk of dying of disease is relatively low. There's also an age component that gets built into that. And so that's the discussion that has to happen. On top of that, as we learn more and more, genetic counseling comes in. What is your family history? What happened to your parents? That sort of thing. We need to know those things. And so that's the way the words need to be used. And in the foundation, I do my very best not to counsel patients. I'll tell them where to go, right? But I try not to counsel them and try to make sure that they're talking to the urologist because the decision-making process is not a one-way street. All this information goes in one ear and out the other if there's a huge risk concern by the patient. And they're just risk adverse. And so they hear C and they want treatment. And then there are other guys who are more interested in lifestyle choices and are willing to forego treatments in order to get another 10 years doing what they're doing. So it's a nuanced problem and certainly is something that needs to be done in consultation with professional consultants and their physicians. Yes, sir. Oh, I'm going to go back first. Who got it? You got it first. You got the light. Go.
Okay, thanks.
No, he has to give up his light in order for her to have the light.
It's not going on.
He has to turn his off. It's the way it works.
Okay, I turned mine off. Back to the Theranostics.
Yeah.
So it works, we saw, like, that is almost miraculous, looking at those scans.
Those
where
guys all died.
Pardon me?
Those guys all died.
Well, this is where I'm going. So at 3 months, you get this more immediate response that's really dramatic, and then the longer-term survival, what happens? What does it
So
lose
it comes back to ideas about dormancy. There were cells that were hiding.
Oh.
You removed the cancer, they came up. Think about your garden.
But you
weed
can't
it,
treat them
other things
again?
come up.
Are they different
Well, they
types
haven't
or-
gotten to treating again, so there aren't,
Oh,
and
okay.
they need to be positive for that marker. And so
Oh.
that's one of the biggest issues. Not all cancer cells are positive for that marker.
Right.
And so you only have that one thing to go after. If the cell decides not to make that thing, which is what cancer cells do first,
Right.
you're after that, I throw it away. So as soon as that happens, then the other cancers can grow and that thing isn't targetable anymore.
Oh, okay.
So there's lots of adaptations.
Right.
Anybody who's seen someone go through a protracted prostate cancer or breast cancer problem, you can see them go from one targeted therapy to another, to another, to another, because the cancer continues to evolve.
Jeez. Yeah.
Okay? Now back down.
So, given that there are just a small percent of guys ending up dying of prostate cancer, and given that there are so many
No. Not diagnosed. 1 in 8
No.
die. Yeah, a few of those guys die, exactly.
Yeah.
Right.
There are so many factors involved there because you don't even have to treat and it doesn't manifest badly, or there are all kind of treatments that you indicate there, either developed from the past or being developed now. So how that interplays with the actual chance of dying.
Yeah, so we've seen an improvement in survival. So the chance of dying has declined, like I said, 40% since introduction of PSA testing, which was originally just early interdiction, right? And so lots of guys got treated, and so when lots of guys got treated, you were treating guys early who actually had clinically relevant disease. Certainly, we're still seeing that play out. We're improving survival all the time. So the thing that doesn't really come out, except for that last slide, is what those survival times are, and that's all comers. But what we're seeing is really prolonged survival. So guys that are being diagnosed with advanced disease are being treated and managed and surviving well past what would have happened prior to those treatments being introduced. So the goal is just to continue to treat this as a manageable disease until, a man's diagnosed at 68. If he's 88, he won the lottery, right? Average life expectancy is 80-something, so if you can live past life expectancy, you've done okay. I hope to live past the life expectancy number. Uh-oh, we're getting cut off.
No. Any more questions? We probably have time for.
Oh, good.
In going back to your graph about the distribution of prostate cancer by race, what factors were explored in looking at that, given the disproportionate representation in African Americans?
Healthcare accessibility. That certainly plays a part. Lifetime exposure. I come from the southeast United States, and the African American There's a study out of southern Louisiana which showed there really was no difference. And so there are really mostly environmental factors. There appear to be some genetic issues related to testosterone levels, androgen receptor mutations that are more prevalent in the black community than the white community, those sorts of things. But I think that it comes down to really environmental sorts of stress.
Thank you.
Yes, ma'am. Oh, good.
Just last, when you put up the indigenous graph, are you guys researching that and why that is?
So the indigenous population problem is there's not a lot.
Yeah.
And in North America, they're all in Canada, right?
Right.
There's almost none in the United States, so there's just not a lot. They're hard to reach, they're hard to keep track of. Anybody who's done any epidemiology in that area knows the story. My wife runs a construction company, and she has indigenous peoples who work for her, and they split to go fishing. They're gone, right?
Yeah,
So, so it's really a problem. So out of our center, it hasn't been a major push, just from a numbers problem. We just don't get the numbers we need to be able to do decent statistics on it. Those are SEER sorts of information that just comes out of global conglomerates of the United States and just everybody they can find any data on.
Yeah. Do you think it's environment, though, with them?
Also other issues, other health-related issues, other probabilities of dying of other things that prostate cancer doesn't get them, survival, just lifetime expectancy, those sorts of things.
Yeah. Thank you.
Yes, ma'am, in the back.
I understood you to say that there are some trials that are only going on in the States.
Not only, predominantly, or in Europe.
So is there any?
Because they have numbers, just they have better numbers than we have. We just don't have enough.
So it's really because of the volume of cases here?
Yeah. And where do you put your few dollars, right? So where do you put your dollars? And so there's from that sort of perspective, there are bigger, stronger centers in those places. Let them do it, because they'll include Canadians in that process where sites will pick those up and where patients can be identified properly. But those few patients that are identified properly get culled into that population for the analysis. We can't run the trial strictly within Canada. We just don't have enough.
So Canadians would be eligible to participate, or is there a cost?
Yeah, as long as the centers are participating. Yeah, so like Kim Chi, who runs our clin-onc program, is a clin-oncologist, right? We need immuno-oncologists that are really driving those sorts of things. And so that's an expertise we really need to build up in Canada. For the young guys who want to do oncology, immuno-oncology. Doesn't have to just be prostate cancer. Prostate cancer may not be solved by immunotherapy.
I want to thank you very much, Dr. Cox. That was an absolutely wonderful overview of prostate cancer. You've given us some great information about novel treatments. One tiny final question. The olaparib, is that a targeted therapy?
It is.
It is.
It targets PARP.
Okay, so I missed that one, obviously.
Okay, yeah, so it targets PARP and is being used really effectively in ovarian and breast cancer.
Perfect.
So why is it those cells? That's a whole nother lecture. Why is it those tissues become sensitive to that when a patient has BRCA mutations in every cell of their body?
Great.
There's lots of stuff yet to learn. Thank you very much.
Thank you very much. So I'd like to now welcome our and I apologize if this is not up-to-date information. I grabbed this off the internet. Always be cautious about what I grab off the internet. So Dr. Dan Bilsker is a psychologist who works with the Center for Applied Research in Mental Health and Addiction. He is an adjunct professor in the Faculty of Health Sciences at SFU and a clinical assistant professor, Faculty of Medicine at the University of British Columbia. He leads a project to enhance mental health care by disseminating brief behavioral interventions for mood disorders in primary care and co-leads a project to identify best practices for protecting psychological health in workplaces. He has produced several depression self-management tools, including a workbook, which is available in multiple languages. Welcome, Dr. Bilsker. Self-management tools, including a workbook, which is available in multiple languages.
There.
Welcome, Dr.
I'm on? I'm audible?
Bilsker.
Good, thank you. So I'm a psychologist, and I've had a focus on men's mental health over the last 10 years or so. It all started when I was commissioned by a men's health research group to do an overview of men's health, to look at all the different factors affecting men's health. It's a great project. I got to speak to all kinds of experts, like the one who just presented so wonderfully, about the various aspects of men's health. A lot of it was new to me. I was more or less acting like a scientific journalist, in fact, because I was interviewing these top researchers about all these different domains. Now, the way I framed that particular, more or less acting like a scientific, kind of like a murder mystery. Why are men dying 4 years before women? And it was commented that some this had been invented. The comment used by one researcher was, as though men had a kill switch. And we just died 4 years before women. Instead of saying why, what's happening? Why shouldn't men live as long as women? So the statistic we then used to examine this was years of life lost. It's a really interesting statistic and gives you different answers from just saying at what age do men die or what are the number of mortalities. How many years are lost? So something that kills a man at 30 accounts for a lot of years of potential life that have been lost. 50 years have just gone. Something that kills a man at 82 accounts for a lot less impact. So we're really interested in those things which are the sources of men losing many years of life. What was fascinating for me as a psychologist is that the second leading cause of years of life lost was suicide. Now, that's a relatively low-frequency event, etc., but the fact is that it happens across the age span, and it happens a lot with men compared to women, and it turned out to be a major contributor overall to years of life being lost by men. That intrigued me, and I then began to focus on men's mental health in my clinical practice and my applied research. The research I do is applied because I want it to be something that will make a difference at a population level out here in the world. I'm not looking to get academic publications. I'm not working for a university. I just have my little adjunct position. But I do clinical psychotherapy and I do this applied work. The aim is to have the mental health system work much more effectively at a large-scale social level. Now, I also did 25 years as a psychologist in an emergency psych unit at Vancouver General Hospital, where I saw a lot about how the mental health system worked or didn't work. And it was quite fascinating that nowhere in that whole career was men's suicide risk ever identified as a major problem. It wasn't really talked about. It wasn't an issue. And that was, to me, rather remarkable. So men's mental health issues and suicide risk, etc., is something that hides in plain sight. The data are absolutely clear. They're quite striking once I figure out how to get the appropriate slides up, so I'm not going to be talking about something I know nothing about. So let's see if this works. There we are. So we're started. Okay. we'll talk about the statistics about why men's suicide, men's mental health, in fact, is a major problem in our society with very little research and very little discussion compared to how large it is. But first of all, to give my overall frame. So when I'm talking about men's mental health, I'm very concerned with men's identity. How men see themselves, how they think about themselves, how they cope with relationships and jobs, etc., all of which really feeds into what we then define as mental health issues. I don't like to treat men's psychology in such a narrow and limited way as to use a kind of medical model and just look at it diagnostically. It's way more interesting and way more complex than that. The medical system, the DSM diagnosis, really, in many ways, has us, and it doesn't actually give us much power. So I look at it overall as what contributes to who men are, how they live their lives, how they find meaning in their lives, how they cope. And the three main sources. One is biology. Obviously it has an impact on who men are, how they operate in the world, what their physical health is, and to some extent what their mental or psychological health is. Another one is culture. And that's very important in this whole analysis. What are the cultural roles men are given? What are men taught about how they're supposed to live, express themselves, deal with relationships, deal with their jobs, talk about their distress, not talk about it? What are the cultural teachings we give men? So think of being male as a cultural position. And that is defined in many ways by the society you grow up in and the kind of life lessons you're given. That's going to turn out to be crucial to understanding who men are, treating men as a class or a category. And finally, there's the one that is almost dropped out of the modern discussion, which is very disturbing to me. My PhD research was on how people form their own identities through a process of taking what they're given, their family and their culture, and rejecting parts of it, and modifying parts of it, and inventing new parts of it. It's that whole area where we choose and form our own identities. Weirdly enough, we have a degree of freedom to do that. Now when identity is talked about, it's so much more about biology, or what is culture, your social roles, what are you made to be. That whole area where you can actually be made a certain way and choose to be different. And the three main sources, one is biology, different. Obviously, it has somehow, and it's the So, keeping that down to different. Obviously, it has somehow, and it's the statistics that are the incidence of male suicide. Keeping that down, and there we see a comparison. Is called the incidence of male suicide. And there we see a comparison. The distinction is not absurd. It's massive. 80%. There we see a comparison. So this is not, again, some little finding that might have been overlooked, not really focused on. It's massive. It's one of the most dramatic findings of all mental health research. And what is because very little has been made of it. So in the course of my training or in my practice or in reviewing the research, there isn't a lot of research about why that is. What's happening here? And I just can't envision almost any other aspect of mental health research that is as dramatic as that distinction. So it's huge. And that I found fascinating, to look at what the reasons might be, what's going on. The other thing that's happened only in the last few decades being identified, it used to be that male suicides would peak in the 20s. Young men, impulsive perhaps, intoxicated, etc., killing themselves. And all of a sudden it's changed. So male suicide rate rises and rises and rises and then peaks in the early 50s. So suddenly it's middle-aged men who are killing themselves at quite a dramatic rate. Again, no one quite knows why. There is no accepted or consensually reasonable, articulated reason as to why that's happening, and there really even has not been a lot of research on that. Again, which is striking and bizarre, because I look at that and I say, this is an astonishing change. Something is going on in our society that is enormous and has huge impacts, and we don't know what it is. We can make theories. Anybody can sit down and say, well, that's because men are being pushed out of their careers or seen as irrelevant, and they no longer see themselves as having a purpose in this world, or something like that. But they're speculations. And there really isn't much research in relation to the astonishingly large pattern we see there. So again, another mystery, something clearly of great importance, but we don't really know exactly what's going on. So I'm going to talk about some of the issues that seem to be related. Oh, question. Similar patterns have been identified elsewhere. They're not exactly the same, but this general kind of shift in patterns seems to be, and it may only be for Western societies. I haven't looked at all the different worlds. I mean, I think it's quite different in certain other cultural groups, and again, there are different forces. But this certainly is a North American pattern that's been puzzling people. Puzzling is probably too weak a word. Okay, now. Oh, yeah.
So basically, nobody knows whether they commit suicide just to show off or because they want to die. That's one thing.
What we have now are theories, speculations, possibilities, preliminary, small bits of research.
And nobody's asking those that try to commit suicide and are not successful in the attempt to extricate answers why.
Yeah, it would be a very reasonable way to start with that. Of course, one of the factors is that when men become suicidal, they go fairly quickly to being very determined to die. There's a whole process when someone starts feeling despairing, hopeless, where they consider dying and they think about it, and women far more likely talk about it, talk to someone else about it, and then the means people use is very relevant. A woman is far more likely to use a medication and try to kill herself that way, hit and miss kind of technique. Men are more likely, let's say, to hang themselves. Very, very effective. Men seem more determined to die. When they make that determination, they go much more quickly and much more lethally into a behavior. So some of the factors that seem to be related to this, and again, it's like a long mystery novel where people are trying to piece it together and there are bits and pieces of things happening. So one of the things that's been noticed is men are diagnosed with depression about half as often as women. And the overall observation had been, well, you know, initially, well, men are just less depressed. Don't know why. One possible reason. For some reason, men do not move into states of depression. Another theory is that men are really depressed, but they won't talk about it. They won't acknowledge it. They won't admit the symptoms, so they don't get picked up in diagnostic interviews. That's another theory. Another theory is that men get depressed, but it comes out in different ways. Instead of being sad and coming out on these studies with sleep problems and reporting those different mood issues, men, let's say, get angry, or they drink a lot more, or they do something else. That's the same kind of depression as that theory, but men show it in different ways. That gets ridiculously complicated because the history of the concept of this thing we now call depression that we treat like an objectively demonstrated thing, as opposed to a paradigm that we place on what people tell us. But the history of depression was, back when I was a young graduate student, there was a lot of debate about what this depression thing was and different points of view, and finally there was this researcher, the psychiatrist, who said, look, enough all this arguing, we can't agree on what this thing is, which we would call the ontology, the essence of what this depression is. Let's just do an operational definition. Now, operational definitions are great. They say, depression is whatever this thing is that you pick up with these 5 criteria. And anyone who says yes to these 5 criteria has the thing. I don't really know what the thing is, but now we don't have to talk and argue any longer about what this thing is we call depression. They said, well, maybe it's a neurochemical imbalance, except no one's been able to identify this neurochemical imbalance. Right? People diagnosed with depression, as far as we know, have serotonergic systems that are just fine. We have no data saying there's something wrong with their neurochemistry, but we tend to believe that. We like to say that. But really, it's an operationally defined thing. People have depression if they show these criteria. And now you say that men have depression, but they don't meet our criteria. We're into a bit of a logical hall of mirrors here. Things are getting really weird. And we now have to go back and start that argument over about what this thing called depression is. So no one really wants to do that. It raises basic questions about what we're doing with our language and our terminology and our diagnostic nomenclature and so forth. For myself, working with people, thinking about suicide, it's really about despair, which is a far more powerful and interesting concept for me. What moves someone into a state of despair, where you feel hopeless about your life and there's no way forward and you've lost your sense of meaning and so forth? That's a description of a human condition that goes back long before we had these diagnostic terms and we thought we knew something about diseases, etc. It's a much more powerful idea, and it really captures much more powerfully the idea that men go into despair. And they seem to be going into it at a much higher rate than women, and let's think about that. What would put them there? So it's an interesting argument. It's really quite intellectually powerful. But we'll keep going with this. One of the things that is related to this is the whole concept of negative emotional experience, psychological suffering, if you like. And you think about how you know the nature of your inner emotional experience when it gets very dark, when you're suffering, when you're in some kind of emotional pain, and what you do with that. So when I'm doing psychotherapy with someone, I say, negative emotions are smoke detectors. They're not important in and of themselves. If I were to sit here, first, if my smoke detector went off in my office and I ignored it, that would be really stupid, because it's telling me something important. So I say ignoring your negative emotional experience is really a bad idea. Your fear, your anger, your sadness, they're actually telling you something that's really important. They're telling you there's a problem in your life situation that's going to require action. On the other hand, if I sat here and really listened to that smoke detector and really got into how loud it was and how complex the sound was and how interesting it is, that would also be really stupid. So just being in touch with your emotions and deepening your experience of your sadness or fear or anger or talking about it in and of itself, it's not all that helpful. What matters is the action. So you start by experiencing that emotional state, then you have to describe it. You have to know what it is. And it's not usually as simple as, I'm sad, I'm angry. Your own internal emotional experience is way more complex than that. And when you get good at describing what's going on inside you, your language is very complex. You may be feeling ambivalently confused about something that's happening, interested in moving forward with an action, while at the same time feeling a certain reluctance or uncertainty and having it remind you of an experience you had a long time ago that didn't work out too well. So when people actually describe their inner experience associated with suffering, it's not as simple as just coming up with some emotion word and expressing it or sharing it. That's not what it's about. There's a whole complex process of explaining or describing or understanding what's going on inside you, and men aren't very good at it. Men aren't trained to be very good at it. They aren't encouraged to come up with complex explanations or descriptions of what's going on inside them. And mostly in therapy, and most of my practice as men at this point, there's a lot of work involved in having them learn the language of describing the complexity of their own inner suffering and experiences. Because once we do that in a complex way, they start to be able to take action that is appropriate and powerful and effective and relevant and is likely to move their lives forward. But if they're blanking out on even thinking about what's going on inside them and believing it's inappropriate to ever share it with anyone else, because that would seem inappropriate or weak or foolish, then the odds that they're going to be able to act in a reasonable and powerful way also get very low. So there's a whole area around dealing with inner emotional experience, dealing with psychological suffering, understanding it, acting on it, that men are not well conditioned to do. The concept, the opposite of that, then we talk about is the Stoic approach. Some of the research I'm doing now is with first responders. Very interesting population. So about 4 days ago, I was in Toronto talking to the Ontario Association of Fire Chiefs. So 60 guys sitting there, all high up in their hierarchy of their firefighting companies. They're all gigantic. And they're men. Talking with them there about what these groups are starting to really be concerned about, which is we've been trained to be stoic. You don't really tune into these negative emotions. You kind of put them to one side. You certainly don't talk about them. You just do what has to be done. You deal with a horrible situation your job requires you to be. You deal with the death and loss and injury and so forth. You deal with it. But what happens is, and what first responder groups have increasingly been calling out, is this starts to break us inside. Over time, these things that we see, our inability to save everybody, the kind of loss that you see, the sort of things you run up again. Most recently, it's been the whole fentanyl overdose epidemic that affects them a great deal. He said, I'm rescuing someone who I'm going to rescue again 3 days from now and then 3 days later. And while I'm rescuing that person, I'm not responding to a house fire. I'm not responding to an accident because I'm doing this. What's going on? This is morally complex. I'm not really understanding what my role is here. And I don't know how this is heroic exactly. All kinds of very complex internal struggles and confusions, and the Stoic approach isn't working that well. And you have them talking about their own sense of despair that builds up over time and the ways in which they feel themselves to be suffering, to be emotionally vulnerable, the suicide rate among first responders, etc., is something that increasingly is coming to the fore. So the people who learn to be heroic and stoic are saying there's limits to this. Yeah, it's really adaptive when you're dealing with emergencies and crises. When you're a soldier, when you're a first responder, it really is helpful to not be dealing with emotional suffering or responding too much. But at some point, you've got to have a way to deal with that. And moral injury is something I'm sure you've heard about. It's become a huge issue in general, starting in the military after Vietnam. People were coming back and they were saying, I did things that I feel terrible about, that violate my moral standards. And I didn't deal with it there, but now I'm home and I'm dealing with it and it's hitting me now. Or it's a first responder who said, there were all these times when I couldn't save people, or I couldn't do what I felt was my mission, and I felt like a failure. I felt that I was doing something wrong, that I had let people down in some fundamental way that imperiled the very meaning of my life. And just, as they say, being told to suck it up just isn't working for me. Right? So it's the soldiers who come back from the war. It's after they come back when their lives can start breaking down. Their marriages break down, their health breaks down, their drinking gets out of control, and so forth. So they're looking for more complex answers and different ways of dealing with psychological distress and suffering. The other thing that is striking about men, 80% overall of alcohol use disorders is among men. Why would that be? I think a lot of it has to do with how men are taught to deal with psychological suffering. One of the things they're taught to do is to drink a lot, drink more. Your relationship is breaking down, drink more. You're having trouble with your job. Here's how to deal with your emotional suffering. And that's treated as though it were a positive thing to do and it's associated with good times and enjoyment. Alcohol is just about the most dangerous drug we got out there. Okay, fentanyl has overcome it. But alcohol is a very, very dangerous drug with all kinds of really nasty, awful effects on people's physical and mental health. It's treated in this society so casually. It's so woven into the fabric of our culture that sometimes it's remarkable to sit back and think about what kind of drug this actually is. And sometimes with clients, I'll say, you're drinking a solvent. It's going to go down through your body, and everywhere it goes, it is going to dissolve tissue. In your throat, in your stomach, in your liver, in your periphery, in your brain. It's going to dissolve tissues in your body everywhere it goes. And we treat this like a casual, good time, social connecting ritual to take care of. I remember seeing a talk by someone who'd been Minister of Health in Canada who said, when it came to dealing with and regulating cannabis, they said, well, let's base it on the policy with alcohol. And she was informed, we have no policy on alcohol. There is no national alcohol policy. The only policy, say at the provincial level, is to loosen the laws, which we've been doing for years now, to make it easier to drink more, because it's so good for the economy. Men do most of this drinking, and men suffer most of the negative impacts. There's a little table like this one. It's from a handout produced by the World Health Organization. And it's meant to hand out to patients who are engaging not necessarily in diagnosable alcoholism, but who are engaging in risky drinking, drinking that has hazardous effects on the health. It's about 15, let's say 20% of men who do this, who drink at a level that will definitely impact their health. And what this nice little diagram does, and I like to hand it out, it shows where alcohol does its magic. Right? This is where alcohol hits your body. And again, it's quite startling. If they were comparing it to cannabis, there'd be no map like this. There's nothing comparable to this. For cannabis, actually the safest drug is LSD, but there's just nothing like this. So alcohol is remarkable, and again, I guess fentanyl can say it finally managed to beat alcohol in terms of horribleness. But this is one of the things that socially, culturally, men are taught to do for psychological suffering. What a bad idea. Here's one of the ways it's a really bad idea. If you think of a guy whose marriage just broke up, who's lonely, who's hurt, who's frightened, and has been socially taught to isolate, right? Don't talk about this with other people. Suck it into yourself, spend time by yourself, and then drink. So, alcohol disinhibits people. I call it the great contributor to destructive behavior, whether it's violence against others or against yourself, or it's ridiculous driving, whatever form it takes. But if you think of someone who's isolated and in despair and hopeless and suffering and doesn't have the language to really describe it and doesn't feel able to share with others, and then you say, drink a lot. It disinhibits. It is a contributor to about half of suicides. Right? You now have someone who's not thinking straight, who's lost their sense of context, who's behaviorally disinhibited. It's like a drug that is designed to facilitate suicidal behavior. Men are known to underutilize available help, not to reach out, whether it's to medical or health type support, whether to reach out, say, for psychotherapy, whether to reach out to family or to friends. There's a kind of cultural teaching to men to not depend on others, to not talk about your psychological distress or suffering, to just not do that, to deny it. And there have been a few times where I've sat with a male client who was discussing some difficult life situation in a very calm, logical, flat kind of way. And at some point I realized this person is in a state of desperation and this person is a big suicide risk, even though they weren't obviously expressing dramatically negative affect. And it's really important not to confuse affect with experience. Somebody may not be expressive, may not be saying, I am so unhappy, I'm so miserable, I could just die. They may not be saying anything like that. And yet, they may be suffering incredibly intensely inside. I remember at one point being called for an interview by an online paper in New York, which is about the food world. It's a foodie magazine called Rub Street. And they said, tell us about Anthony Bourdain. How could he kill himself? He was admired by so many. He was so successful. And I said, look, we all have an outer story and an inner story. And it's the inner story that determines what's really going on for you emotionally and psychologically. The outer story can look wonderful. It's the one you put up on Facebook. The inner story is what's actually going on internally, and they can be very discrepant. And if men are trained to have their outer story be controlled and rational and flat, their inner story may be radically different and not really known by others around them. And in a couple of cases I can think of, they really had told nobody any of it because they felt it was their duty honorably to deal with this, and they felt they'd completely blown it, and they felt that desperate hopelessness, and those are the foundations for suicidality. So men tend not to reach out for the help. And again, it's part of the training, it's part of the social conditioning. It's part of what needs to be changed. So how do men cope with psychological suffering? One is to deny that it's happening. Again, not to articulate it, not to be even very good at describing what's going on inside, not to express it to others, to generally isolate, to cut off from other people, to pull into yourself. To drink more. Of course, we just talked about that. It's another traditional social solution to feeling bad with all kinds of terrible implications. And then to get angry. And that's kind of a fascinating one in the culture, how men are almost conditioned not to think of anger as an emotion. Some years ago, my wife was registrar of the College of Psychologists. She was dealing with a senior psychologist, and he was really irate about something, going on and on and on, just about escalating his voice on the phone. And she said, you know, let's deal with this without much emotion. Let's not get too emotional about this. Which, of course, sent him through the roof. It was just ballistic. The whole concept that he was being too emotional, when in fact he was being enraged, which we all know is not an emotion. So telling men that somehow anger is different and it's honorable to be angry is actually a really terrible teaching, because anger is a vicious emotion overall. It destroys as many lives as depression or anxiety ever have. We don't really have a proper diagnostic category. It just shows that it hasn't really been seen as a source of pathology. But the men I've worked with anger issues are extraordinarily lonely individuals because other people don't want to be around them. Right? You're with someone who's an angry person, and they may win the argument or the discussion because everyone wants to get out of the room. Right? No one wants to hang out with them. Once I had a guy come to me, it was really quite touching, who was a successful business person in a very competitive business. And he said, you know, I come home, and my wife, my kids, they've arranged to be away doing other things because they know that I'm like irritated. And I'll snap at them. They want nothing to do with it. He said, I'm incredibly lonely. Right? I love my family. And I found that very powerful. And you can really see that anger itself, though we don't have a major anger disorder in the same way that we have major depression and so forth. It's just as endemic, and for men, it's just as powerful. Okay? So teaching men how not to be so angry has turned out to be a really important part of their therapy. Because just as people have to learn how not to be so depressed and look at the pattern by which despair and depression are created, or anxiety disorders, people really need to learn how not to get locked into patterns of anger, how not to live their life in a state of bitterness or resentment or fury or enrage or whatever form it takes. There's a whole process, there's a way of thinking about the world that builds anger. Right? There's certain definite cognitive strategies people have implicitly learned that create a state of anger. And men are much better at those cognitive strategies. Magnifying how much other people have hurt you, portraying others with insulting labels in your own mind, seeing others as letting you down. There are all kinds of things you can say to yourself. Think about when people are driving. I've had people come to me with driving anger. And I said, tell me about that person who got you so angry. Well, he was driving like 20 miles an hour or something. But it was ridiculous. Tell me about this person. Why was he doing that? Well, he was about 75 years old. Why do you think he was driving more slowly? Probably because it wouldn't have been safe to drive faster. Okay, let's take everyone off the road over 70. He said, no, I don't want that. I'd like to be able to drive. We had to look at the way he was talking to himself, the names he was calling this person, the outraged, indignant self-talk that was building up his anger until he did something stupid and cut the person off and could have had an accident, and sort of realized himself how dumb that was. So the pattern of building anger is much more associated with men. It's a pretty amazing quote from Philip Zimbardo, who's one of the great psychologist researchers, from a fairly recent book that he wrote about men. So he's talking about what it's like to be a young man now, and he's saying it's actually, in some ways, getting harder. It's becoming more difficult to like yourself, to feel good about yourself, to see yourself as an honorable person. And there is some risk of masculinity itself, being male, being treated as a kind of disease, as a major problem, and a decreasing number of positive male role models. How do you become a man? How do you do it honorably, acceptably, pro-socially, positively? How do you do that? People learn that by looking at models, by having certain messages, by being given a guidance. And he says that's really failing. They aren't being given that guidance or that sense of role models. He does point out how few elementary and middle school teachers are male. I think it's a huge problem. Among boys who have fathers, the amount of time they spend in one-on-one conversation is much less than the time they spent in front of a TV, where men increasingly are represented in these caricatured, stereotyped ways that aren't very helpful. As he put it, emotionless warriors, hapless dads, or losers who can't get anything right. You can't envision a future that is honorable and pro-social and supportive if you don't have models and you don't learn how to do it. So his argument is, as a society, we're failing a lot of young men. So as a clinician, what do I advise people when I'm doing teaching around working with men? Reflect on your own assumptions about men, what you see in front of you, what your stereotypes are. We all have caricatures and stereotypes. And just reflect on those and challenge them. Don't assume you know just what's going on from these assumptions, from the stereotypes. Don't confuse expressed affect, as I said, with suffering. Someone who appears, I've had at times in my work, in the emergency, I've had military vets come in. And what struck me is they would talk about experiences that were absolutely awful in very level, logical, straightforward ways. And they would describe situations that were just unimaginable in terms of moral injury. Someone who had been in Rwanda talking about being in the observer post as the genocide began. And they were calling head office, basically. We need to do something. No, you're observers. Observe. It violated their mission to help people, to save people, to be there, to be heroes. They were told to observe a massacre happening. And for a lot of the people who were there, it just broke them. But the calmness of the way they would, these few vets I had would talk about these kind of experiences, absolutely flat. I was once at a military mental health conference, and one of the soldiers said, when I'm on deployment, he said, I'm a mobile weapon system. I thought, yeah, I can see that would actually be adaptive while you're there. But how do you switch back on your humanness when you get home? I was once talking about sort of moral injury. Oh, I digress. That's my form of being male. I was traveling. I was in Vietnam. I was sitting in a cafe in Hanoi, a very nice cafe, chilling out with my wife. And I realized at the table behind us, a Vietnam vet had come back to Hanoi, and a lot of Vietnam vets had come back to Vietnam to try to reconcile what happened when they were there. He was talking about it. He said, I was 18 years old. I didn't know anything. They sent me to Vietnam. They sent me in a demilitarized zone. They said, anyone who runs away from you is Viet Cong. Kill them. Anyone who has too much food is feeding the Viet Cong. Kill them. Kill all animals. They're all food. He said, so I did what I was told. And he spent the rest of his life trying to come to terms with the horror of what he had done, trying to reconcile what his own moral status could be. So that's the whole moral injury. But again, spoke about it in a fairly level way, and it had taken him years to be able to be in touch with some of the emotion, some of the feelings, some of the reaction of what that meant. So that's the moral injury that's also coming out. Male-appropriate therapy, I guess, in terms of how we'll develop our therapeutic methods, I think we need to adjust them to be more appropriate to who men are, how they've learned to operate, what their issues are. And monitor alcohol use. I have made a point of that. I've learned more and more, really to probe that a bit, because people always lie about their alcohol use. Oh, just, what is it, drink or two. You drink 3 or 4 drinks, maybe in an evening, maybe on the weekends I'll have like 8 or 9 because, or I'm a wine appreciator. I love that one. I'm not alcohol dependent. I appreciate wine very much. My wife and I appreciate a couple of bottles each night, right? Monitoring it as an issue. It's important. I was once teaching about brief interventions for alcohol use, depression, and so forth to a group of physicians, group of family docs. And one of them said, I was talking about hazardous alcohol use in men affecting about 20% of men, and he said, I don't think that would be true in my practice. And he had a very, very upscale practice in a very wealthy little community in West Vancouver. And he said, I don't think that could be true for my population. And I kept on, and then he stopped at one point and said, excuse me, what I said was ridiculous. As he began thinking about his people who were very wealthy and prosperous and drank a lot. As much as any downtown East Side person who didn't have much money, they just drank differently. They drank higher quality wine that would kill them just as fast. At a population level, I think the tendency to stigmatize and caricature and vilify men is very powerful, and it's socially incredibly dangerous because it disrupts the ability to have that conversation. At one point, I was interviewed on this CBC radio thing about the Gillette ad. Gillette had produced this ad about toxic masculinity and so forth, and I said, I think it's really badly done. And the person who was the host, very nice person, said, why? I said, because you don't start a process of change by shaming and vilifying the people you want to change. The small proportion of men who are truly abusive and violent will just laugh at it. But the rest of the men will feel offended and alienated by it, and they won't be talking to you. There's no more discussion. The discussion's over as soon as you shame someone. If that's your approach, if I did that in therapy, my effectiveness would be 0. You begin by respecting someone. You want to know what their strengths are, what is the source of their honor and their sense of virtue, etc. And then you identify what some of the coping patterns or the ways of being that are really not good for themselves and the others around them and their children and their families. But you start by recognizing the strength and the courage and the determination it takes. And again with men, you have to keep in mind that all workplace deaths are male. It's just one of those things. You've got to keep it in mind. 97% of workplace deaths happen to men. And it's not because men are big, ridiculous risk takers and idiots. It's because our society places men in all the dangerous jobs. We fill the dangerous jobs up with men. And I'm not sure if equality someday means as many women will die on the job as men. It seems like a pretty perverse thing to be aiming for. But it's worth keeping in mind. And when I see someone who is in fisheries, in logging, those incredibly dangerous jobs, in the military, etc., I'm grateful to that person because they're doing something we need that is really dangerous and I cannot imagine myself doing. So I'm filled with respect and gratitude for what they do, and if they're stoic about the consequences and they're not complaining about the risks and they're just doing it, I start by being incredibly impressed by that person. And then we can take a look at what their issues or problems might be. But it would never be by denigrating the courage that they show in dealing with it, which is part of Stoicism. So this whole toxic masculinity thing, incredibly poorly defined. I don't know if they mean a proportion of men or half of men or a quarter of men or all men. It's left very vague because essentially it's an insult. Essentially it's meant as a demeaning label. It's used that way. And I don't like vague, I call it weaponizing ambiguity. It's a very dangerous thing to do because it slides over into stereotype and horrible social practices very quickly. Provide targeted services. The Australians have been big on that. They produce these programs designed to set up information booths at sports events and so forth. They have these things they call men's sheds. We have some of that too, which is a place where men come together and they build things. I should point out, these are things I know nothing about. I've never watched a sports game. I couldn't imagine something more boring. I've never built anything. So I totally don't fit into male identity in all these ways. But this idea of reaching out to where men are and where they naturally gather seems like a really good idea. So for me, they could do this at a rock concert and I could understand it. I'd be there. Enhancing men's coping. I think there's a huge potential to educate men to cope with relationships and jobs and their personal health in a much more effective way. One of the observations in these first responders is they come into that work in peak physical shape, just amazingly fit and strong, and then gradually deteriorate physically until they're in their 40s and 50s, and of course, they're having that whole loss of physical fitness that is so common for men and contributes to all those heart attacks men are having in their 50s. Women are better at maintaining their physical health and fitness than men are. That has to change. There's no reason for that. Part of I think, a social population level intervention to change how men cope. The project I've been most invested in for these last 10 years, is teaching coping skills, psychological coping skills. And I produced this set of workbooks, one called the Antidepressant Skills Workbook. They're up for free download on the web, and I've had about 1 million downloads of these books over the last 10 years. We have them in English and French, Punjabi, Vietnamese, Farsi, both scripts of Chinese. It's currently just hit China big time for some reason, and now we're getting more Chinese downloads than English. Such a big population, spreading quickly. But the aim for that is to say, this is what we've learned in cognitive behavioral therapy research. These are skills that are really effective for dealing with mood issues. Step by step, here's how you do it. Here's an audiobook version, etc. Here's a version for adolescents. We had funding to do an adolescent version. We had funding to do one for the workplace. They're all free and they're all up there. But the possibility of enhancing coping at a population level is something that I think is extraordinary and minimally really done. Finally, funding research. Imagine research were funded in proportion to the kind of drama of those findings, those unprecedented distinctions. 80% of alcohol use, 80% of suicides, 80% of fentanyl overdoses are men. Again, fascinating, extraordinary differences. The research funding allocation does not even come close to corresponding to that. Men's mental health research is tiny. But the actual problem is utterly enormous. I'll just touch on this quickly. Okay, very fast. Doing the first responder research, what I started by saying was you're all interested in enhancing what's called psychological resilience. Well, let's find out what makes a first responder resilient. So we did a survey study of all the paramedics in BC. Got about 700 responses, so we had some data. Did a factor analysis, which is so much fun to do, which is designed to say what are the key dimensions of psychological resilience in this group. And we came up with 5 categories, which I think is going to apply in a much broader way than just this population. What makes someone psychologically resilient, able to resist the impact of highly traumatic stress exposure, able to recover from it. Having a sense of balance between the work and your life. So these first responders who over-identify with the hero role in their work are very vulnerable. When things go wrong, their marriages start losing their life. They stop focusing on their marriage, on their hobbies, on their friendships, on anything outside of the job. Very dangerous way to live. Extremely vulnerable. Increasing self-acceptance. Self-compassion is the other term that's used. Not judging yourself harshly for what you haven't been able to accomplish in relation to what you believe is your mission. The hero who can't save everybody. Right? Being self-compassionate, having self-acceptance is a huge protective factor. Having meaningful work, the relationship between your personal values and the work you do and how you coordinate those, how you keep them consistent is really important. Having trusted social support, having some people, peers, family, friends who you really trust and you can talk to about what's going on is a very powerful protective factor. And physical self-care. That's something else they identified. If you let yourself fall apart physically over the years, you're much more vulnerable psychologically, emotionally, etc. You have to keep yourself healthy. They talk about eating, they talk about exercise, etc. Those were the factors that emerged from that factor analysis, and now we're busy designing a resilience coping training built on those factors, which ideally would be out there at a very high level in terms of distribution. It's not just something you pay to see a psychotherapist for, but it's out there to all first responders. That's the goal. And it's relevant for men. If you want to enhance the way men cope with suffering, get it out there at a population level, engage them, and give them messages that the way you might have learned to be a guy may not be safe for you and for the others around you. If you've learned to have anger as a coping response, it's terrible for you and it's pretty bad for your family and your partner. You have to learn to be non-angry. You have to learn how to do it differently. So there's that antidepressant skills workbook. Just put it up there. Just search that term and you'll get there. It's free download. In one of the workbooks I was funded, anger was coming up as an issue. That was about people with chronic health conditions, and I was talking to caregivers, and they said people get really angry that we can't fix them all the way we should. That's a real problem. It messes up their relationship to the clinic and so forth. So you can just look up Managing Anger, PCHC, which is the acronym for that book, and it's really relevant for men, where anger is one of the most common, devastating, destructive patterns. And then a US site called Rethinking Drinking. Did a really nice job of addressing risky alcohol use and getting people to look really seriously at what they're doing with alcohol and how it's affecting them now and in the future. There. So that was what I needed to talk about. Here's an image from a lovely place in Turkey called Bodrum, which the year after I was there became the main jumping off point for for refugees, from Syria. Strange place. So, thank you very much.
Yes.
Okay.
Sorry. My question is, how do people access the services that you have described, like psychotherapy?
Not so easily. So the public mental health system in Canada does not provide really effective psychotherapeutic services, which is pretty much cognitive behavioral therapy has beaten everything else out in terms of the evidence. Our public system doesn't do it. The American system isn't bad. If you have health insurance, you get about 10 sessions of CBT covered. The Europeans are amazing at it. I was giving a talk in Amsterdam to a research group. They said, how do people access CBT in your system? And I said, well, they don't. And she said, perhaps I've not expressed it properly in English. I said, no, you really have. So if you lived in the Netherlands or in Germany or in the UK, etc., and the UK has invested massively in providing CBT to the whole population. They've spent $1 billion on that in these last few years. Canada is way behind those other sites. So people essentially, hopefully have extended health coverage through their employer, and then they get covered for a certain number of sessions. If you're an airline pilot, you get unlimited coverage. If you work for Starbucks, you get 3,000, which is pretty good. So there's quite a variance. And when I worked in the health system, I had no coverage for psychologists if I had wanted to see myself. But now they give like $1,000 a year, so yeah. Yeah.
I was just wondering, if you look at attempted suicides, does the gap between men and women still stay that significant?
No, it's reversed. Women are 3 times as likely to attempt suicide. So a lot of this has to do with men being very determined to die and using very lethally effective means. And it's exactly the kind of research that would be worth a dozen different studies to look at that difference and really try to pin down, through interviews of survivors and so forth, what happened, what's the difference. There's some research, but not nearly enough. Yeah.
A little bit theoretical question here. I don't want to misrepresent, but I think men are a little bit more action-oriented, geared to fix problems, fix things. Like, if there is a problem, let's address it, rather than discuss much about it. So when they are faced with issues, basically seems to be a breakdown in ability to solve the problem. Many a time, those problems are external. So all the coping mechanism, all the thing that you presented, which is very good, but there isn't this element of how you address external problems. It's almost like how to cope with them, how to almost forget about them, how to move, just continue to suck it up, ultimately. So how we address these things.
So when you're dealing with outside external situations that are complicated, what people have to realize is that their own response to it and the meaning of that situation
Your call
for them
will be disconnected.
is fully disconnected, is not simple. That your own reaction to it is very complex. And the reaction, I've had people come to me, say a scientist who's running complex research with a large team and doesn't know how to run a team, doesn't know how to deal with them and their different needs and approaches and so forth, and just thinks that it's somehow his own anxiety. And we had to go through what's going on in that team. What are people feeling? What are the different motives? How are they interacting? How does that make him feel? What does he think about it? We had to go into a great complexity before he could even resolve the problem. And then he could, but not till then. So if you don't really understand the complexity of what this means to you, what is going on with your own response to that, and the significance of it, and what your goals are, and so forth, you can't really get to just solving the problem. Because it lives outside, and it lives in all those people, and how they interact, and how that affects you, and how complex it is internally. Imagine it's a problem in a relationship. It isn't just a practical thing that just needs to be solved. You really have to understand what it means to you. And that means going in a complex way. Okay. Yeah.
Just wondering if, how much is there any factoring of hardwire? I mean, men in the northern part of the northern hemisphere have been thousands, millions of years, been hunters. 80% of the violence is done by the male in the northern hemisphere. We're a bit of a violent creature, and so would suicide not be a very easy thing for a male to do?
So in relationship violence research, it's about a 60-40 thing. Men are about 60% likely to be violent, women are about 40% of the violence, but the men are stronger. So the violence they do harms more, so they hurt more. Right? So being physically strong, for sure, is a biologically based kind of difference. As to whether there are in fact biologically based differences in how aggressive men are and so forth, it's really unclear. It's really not well defined in the research. That's an assumption we make about how it is. So when I began reading about masculinity and what it is, and I thought of all the men I've known, I thought, I didn't know any of those men. Right? If you said masculinity is all about a focus on humor and comedy, I would go, yeah, I know those guys. I grew up with them. It's a love of certain kinds of music. I go, yeah, I know those guys. But it's this violent, aggressive thing. I say, I don't know them. I've read about them. I know they exist. So I think there's an immense malleability of who people are. I think people are far more fluid and transformative than we ever would thought. We've certainly discovered that about women. Right? They can be as intense, as aggressive, as powerful, as strong, as action-oriented as any man, if you allow them to, where it's relevant. And I think men have much more capacity for being very different than we've ever accepted, or else we lock people into these models. So some of it's biological. I don't think that much.
In preparing for today, I did speak with the Ministry of Health regarding the men's health program in the province and found out that it doesn't exist. And from a health services perspective and a health planning perspective, is it appropriate to have a woman's strategy for health and not have a men's strategy?
Yeah, I think it doesn't make sense for any of us. We actually all live together. We're in families together, we're in relationships together, we're just all intermixed. So if you say we need to have a strategy for enhancing women's involvement in STEM research and STEM professions, I say that's great. Now let's have a strategy for enhancing men's involvement in the school system. Let's have a strategy for enhancing men's involvement in psychology, right, which is soon going to be 90% female profession. I think that's an awful idea. So in general, there should be a men's health strategy and a way of getting the genders involved in these other areas where there's been an unnecessary restriction or limitation or narrowing. And yeah, I think it has to be both, or we create just another troubled form of society. Yeah.
Thank you. That was a wonderful talk and very thought-provoking. Just following on the Diane's comment and your response, and also thinking about the term toxic masculinity and whether we know individuals who act that way or don't, or whether it's a stereotype, to be a little perverse. What you're describing is misogyny. That's why there aren't men in healthcare and teaching, because it's women's work. That's why all the men are in forestry and fishing, because that's man's work, and why they're first responders. So I think of course we need to pay equal attention to where people are missing in different fields and inequities. But I think we also have to keep the other side of the coin in mind. And we had a women's panel discussion earlier today. I hope next year we can integrate those conversations, because you can't talk about strategies to get men into teaching unless you talk about getting rid of the misogyny or the stereotype that says women are care providers and educate children.
Yeah, unless you loosen up those stereotypes and you allow the fact that there's more variability within a gender than between them. So men are more different from each other than men are different from women, and the same is true for women. Enormous variability in the research among women. And not to assume there's this similarity or caricatured narrowness on each side. It's a false model, and it unnecessarily limits people.
The men's resiliency coping model that you shared had 5 categories. I think the last one was physical self-care. I'm wondering if spiritual health care, if a faith component or existential component, if the research would show that there's value in adding that to the model in terms of both causal and treatment.
Yeah, so the spiritual aspect emerged in some of the interviews we did. We also had a free text box where these 700 people could comment on anything else. So definitely there were a percentage, 15, 20%, who talked about spiritual aspects, helping them get through these really awful experiences through their faith. I think within those categories, it probably ended up lumped under something like self-acceptance or self-compassion, became part of having this spiritual input to that. And also, to some extent, on the balance. Part of what you balance your work with is what you personally believe, your involvement with faith, for example, or your personal sense of there being this meaning in the world is a way of balancing the demands of that job. Okay, yeah?
Just one more footnote about accessing cognitive behavioral therapy. In general, you're right, it's very unavailable in Canada, but there are a few local options for people in Victoria. I think there's a wait list, but there is an 8-week course that's covered under MSP. And I think there's also a course available for people who are diagnosed with depression or anxiety in a few places. So you can ask a GP or do a Google search. I think one of the organizations that offers it's called Mindfulness West.
Okay, thank you. All right, thank you. Okay.
So I wanted to thank both of our speakers. That certainly raised You can help me out by picking a ticket.
Does everybody have a ticket? Okay, anyone need a ticket? Okay, our first winner, 587915. Okay, winner number 2, 587907.